Hi, everyone. My name is Kimberly King-Spohn. I'm the director of the WellStar Center for Genetics. Today, I am going to talk to you about a subject that's near and dear to me. That is the role of genetics in evaluating patients for risks of common conditions. We're going to focus primarily on some common hereditary cancer syndromes and cardiac conditions that we see within our office on a regular basis, and talk a little bit about what our patient interaction is like and how we provide services to those patients. First, I wanted to talk about this interaction between genes and environment, because this comes up all the time with our patients. Patients come in and they want to focus on their family history, who in the family might have a condition of concern. And it's really complicated because while we share genes in common with our relatives, we also share a lot of environmental risk factors too. So you might see a clustering in a family, for example, of heart disease. Is that always purely a genetic condition? Before we get too far into my area of expertise, which is genetics, I want to acknowledge the huge environmental component to those as well. We know that diet, exercise, other environmental pollutions like the air we breathe, the water we drink, the sun we're exposed to, those all impact our health too. And we share those in common with the people that we're related to. So it can be hard to figure out what might be genetic versus what is environmental. And at the same time, the environment always still counts. Even if we're talking about something that is a hereditary condition, the environment still plays a component to that. So basically, my comment right off the bat would be both are important, both interact to prevent or cause a disease. And our genes are not our destiny. We're going to talk about some hereditary risk based on genetic testing that we can perform for patients. But even if a patient is identified to have a hereditary predisposition to a disease, that does not typically guarantee they will develop that condition. There's still other factors like their environment that they interact with that can influence that risk within a patient. So we usually say, like, your genes aren't your destiny. They're just an opportunity for us to determine who might be at higher risk than others. And we can't control the genes we inherit. We all have genes that we inherit from our parents that might have a negative impact on our health. We all have genes that we inherit, hopefully, from our parents that have a positive impact on our health and other aspects of our life. So it's something that we're all in this together to some degree, and genetic testing can just help to predict who might be in higher risk categories for one thing or another. So we all probably have genes that fall somewhere on the spectrum of negative or positive impact for our health as well. Most of us just don't know what they are. I want to, as we move into the conversation more about genetics, first talk about what happens as part of our interaction with patients. As I said, I'm a genetic counselor. A genetic counselor has a role that I think is quite interesting in the field of medicine. We are there to walk patients through the process of assessing their risk for a genetic condition, talk about different interventions like genetic testing, what that might mean for them and for their relatives, and then support them through the process of making informed medical decisions based on that information, sharing that information with their relatives. So what I usually tell patients when they come into our office is, my only skill really is talking. We don't have any physical invasive procedures that we provide to patients. Our genetic testing is usually these days like a buccal sample. You don't typically even have to get your blood drawn. We spend a lot of time talking. We take a very detailed medical history of the patient, usually at least 3 generations. So themselves, their parents, their grandparents, and then if possible, the generation below them if they might have their own children or even grandchildren, to look at patterns in the family to figure out who in the family might have had a condition, how old were they when they had it, how are those people related to each other, so we can map that all out on something we call a pedigree. We also review the patient's medical history. We are looking at their own history of a particular condition, if that's appropriate. We have a pathology report to review, or imaging that we might review, or previous genetic testing that might have occurred in the family, things that can help us add context to our risk assessment. And then we provide a lot of education. We're having conversations similar to what you and I are having today, where we're explaining the role of genetics in a disease like cancer to a patient. We're kind of walking them through the process, or in some cases, cardiovascular health, and we'll talk about those things. And then what do we do with that information? Is there a role for additional screening? or like a procedure that we might offer to lower that patient's risk or try to prevent something from occurring in the first place. And then talk about how they can share this information with their relatives. As we tell patients, you and your relatives share genes and environment in common, as we just discussed. So any kind of genetic testing result we might get for you is something that your siblings, your parents, your children, other relatives might be impacted by that as well. And we might want to talk about how to give them data that they can take to their own healthcare provider to make an informed decision as well. Just because I really like genetics, I want to talk about how we get here, specifically with cancer first, and then go into cardiac genetics as well. And within the cancer world, I want to talk about the fact that all cancer is genetic. All cancer is caused by changes in genes that allow cells to grow and divide at an increased rate, which then can trigger a tumor to develop. And we all inherit, thousands of genes from our parents, but the majority of the time, it's not those genes we inherited from our parents that cause us to develop cancer. It's something else, something in our life, in our environment, something as part of the normal course of aging. So this schematic is a very popular one in our world. It's called the two-hit hypothesis. It's to help people to understand that most of the time, these two hits or mutations that occur in our DNA that we have are not something we're born with. They're something that just occurs as part of our routine walking around on this planet. And that's why most cancer occurs in people as they get older, as we're just exposed to more things, and our DNA just isn't quite as precise as it was when we were a young individual. In our patients in our office, what we're trying to determine is, are they born with a copy of one of those genes that's already not working? And these are specifically genes that we target that are called tumor suppressor genes. Their job is to protect you from getting cancer. We all have them. We want them to be working, doing their job. So when we do the genetic testing, we have collated onto our test a collection of genes that we know are responsible for protecting a patient from, whether it be breast cancer, ovarian cancer, prostate cancer, things that we're going to discuss. And then we're looking to see if we can find a change in any of those genes that cause them not to work. That really means that that patient might not have been born with the protection that we would have ideally expected. And that's what puts them at higher risk to develop cancer themselves. They typically are not born with cancer. These are not childhood onset risks that we're talking about. These are still adults that develop cancer in their lifetime. And that's because they have two copies of every gene. They got one from mom and they got one from dad. So in this case, one copy of the gene is not working when they're born, but they still have that extra copy protecting them. It's only through the course of time that they acquire that additional mutation, again, either through some environmental insult like diet, exercise related factors, smoking, alcohol exposure, just also random errors in cell division that can occur as we get older. That can trigger that second, we call second hit, and then that will develop into a cancer for that individual. So the philosophy behind this is that if you have a hereditary cancer syndrome, you are not born with cancer typically, but you are more predisposed to develop that cancer because you only need one random event to occur in your lifetime in order for that to happen, where the average person needs two. And that cancer tends to occur at a younger age because it's something that it just takes less time in our life for that random event to occur. So for example, we commonly think about breast cancer. Women, the average age of onset of breast cancer in our country is about 63. If you have a hereditary predisposition, your risk to develop breast cancer is over 50% by the age of 50 with some of these genes. So that risk is pushed down to the younger age. So that's what we're talking about in this situation. So I think that's interesting, but I also really like genetics. So I might be influenced by that. I wanted to, again, use genetic breast cancer as an example of this. We know that the majority of things like breast cancer are sporadic. The majority of people who develop breast cancer don't have a family history. They don't have any other specific risk factors. So in this case, this purple part of our pie graph here, these are cancers that occurred by chance. And the vast majority of women who get breast cancer, and I could extrapolate this pie chart to most every other type of cancer as well, don't have any risk factors we could identify. in this case, except for perhaps being a woman. We know that obviously that's an influential risk, although it's not an exclusive risk. And things like ovarian cancer obviously only affect women, prostate only men. Otherwise, there are no other risk factors we identify. I point that out to say this is why all people should be getting screening for the cancers that we think about in the population. It doesn't matter if you have a family history. It doesn't matter if there's any environmental risk factors you may or may not have. A woman who has zero family history of breast cancer, who's a vegan marathon runner, does not have a zero risk. But in our office, we're looking for these folks in this blue bar here. These are folks who have a strong predisposition. They were born with that one hit that we talked about on the previous slide. About 5 to 10% of all breast cancer is hereditary. That's a very similar number for other cancers as well. It's a little higher for a few, but for the most part, about 5 to 10% of all cancer is hereditary, meaning the vast majority of people we offer genetic testing to are going to test negative because they don't have a hereditary predisposition, which is a good thing. But it also means we're back to where we started, and I don't have an explanation for what caused their cancer either. There is this middle of the road category, these folks in this like green area of the bar. This is what we call familial cancer predisposition. This is that concept of shared genes and environment. We might see a cluster of cancer perhaps in like multiple sisters in the same family. Is there something genetic we don't understand, or is there some shared environmental risk factor that was unique to that siblingship that we don't have a way to quantify? So having a family history still counts, even if you don't have a genetic risk that we can identify with testing. But again, those are both together a smaller portion of the pie than just sporadic cancer by itself. Whoops, what makes us suspicious that something could be hereditary, these are the things that we tend to look for in our office. These are the clues or the red flags that would trigger us to offer somebody genetic testing related to hereditary cancer. So when we're collecting that pedigree or family history, this is the information we're exploring. First, we're counting how many people in the family had the same type of cancer on the same side of the family. So this is like everybody on mom's side or on dad's side. We're not adding those cumulatively together because in theory, you should not share genes on both your maternal and paternal side. Those should be two separate lineages. So for example, if you have like a maternal grandmother and an aunt and a mom who all had breast cancer, that would be like 3 individuals on that same side of the family. That magic number of 3 is very common for us with hereditary cancer. Or we might see on dad's side, 2 uncles and a grandfather who had colon cancer. That 3 individuals is a red flag for us. We also look for multiple generations that can be affected. This is another clue. So if we see like a parent-child who both have the same type of cancer, that follows the possibility of a gene passing down through the family. So that makes sense to us that maybe there's something hereditary going on there. We also look for certain cancers that can appear together genetically. So our most common examples are like breast and ovarian cancer. They tend to go together genetically. Also things like colon and uterine cancer. With pancreatic cancer, we can see like a pancreatic cancer melanoma syndrome. So we're looking for those common patterns that would make us suspicious. We also look for rare cancers that are more likely to be hereditary. Things that tend to fall into this category are things like triple negative breast cancer. That is a more aggressive type of breast cancer and has shown to be more likely to be a hereditary cause for breast cancer. We also see like ovarian cancer is a rare cancer, much more likely to be hereditary. All of those patients should be offered genetic testing regardless of their family history. Additional examples would be things like male breast cancer or a more aggressive prostate cancer. Those are automatic triggers for referral to our office. But by far, the most concerning thing that we look at is age of onset. And that gets back to that same concept of that 2'd hit, where it should, in the average person, should take a while for cancer to develop. Again, it should be something that occurs over the course of a lifetime in 60, 70, 80 years. If you're seeing cancer in people in their 30s, their 40s, even their early 50s, they just haven't walked around on this planet very long. And it makes you wonder if there's some kind of a hereditary predisposition as opposed to something environmental that's triggering that cancer in that individual. This is just an idea of autosomal dominant inheritance to remind you, this is like high school biology class, of how genes work. So we all have, again, 2 copies of every gene. We get one from mom and one from dad. The vast majority of these hereditary cancer syndromes that we're going to talk about, and also some of the cardiac conditions we're going to talk about, are what we call autosomal dominant conditions, meaning you have 1 copy of the gene that's working and 1 copy that's not. And then there's a 50-50 probability which of those you pass on to your children. So in this situation, if we have 2 parents and the parent on the right is affected, if they have that copy of the gene that's not working, there's a 50-50 probability which of their children they might pass it on to. But it doesn't work perfectly. It's just like gender is a 50-50 probability, right? You could have 4 children, all 4 of them could be girls, all 4 of them could be boys, you could have 2 and 2. Even if you have a mutation, there's a 50-50 probability for each of your children independently to inherit that change. You could have all affected, all unaffected. It's just something that is unique to each of those conceptions. So we keep that in mind, but we tend to see patterns of multiple affected generations. And if you're unaffected, if you didn't inherit that mutation, your children are not at risk because you don't have that mutation to give. So that's helpful in some of these families to understand that concept as well. Why does it matter? What's the big deal here? We think about things like, again, hereditary breast cancer. We know that having a mutation in one of these genes puts you at significantly higher risk for cancer than the general population. So these purple bars are the risks in people who have a gene mutation, like a BRCA gene mutation, which is the most common hereditary cause of breast and ovarian cancer, compared to the general population, which are the folks with these green bars. So as I said, it's a much higher risk by a younger age. And we want to treat these people differently. We don't want to just, do a mammogram starting at 40. We want to offer the appropriate intervention based on that level of risk. So if we find these patients, we can better match up their medical management options based on what's going on with them. And let's talk about that. So this is just an example. We have a lot of genes we know associated with hereditary cancer, but I just want to walk through the scenario of what this can mean for somebody's health. In this situation, if we have a woman who comes into our office, we do genetic testing on her. She's identified to have a BRCA gene mutation. She gets put into a different risk category based on the data on the previous slide. We're going to treat her differently. We're going to offer more aggressive options starting at a younger age. So at the minimum, she's going to be offered breast screening starting at 25 years old, which again is considerably younger than the general population. We usually start with a breast MRI at that age because it's really hard to do breast imaging in a very young woman because of dense breast tissue. As she gets older, into her 30s, we're going to add a mammogram to that, also done yearly. Ideally, we tend to alternate them so they have 2 touch points throughout the year. So they're not getting all their screening done in 1 week and then going 12 months in between. So they might get a mammogram in January and a breast MRI in July, and then continuing on that cycle so that they have the opportunity to meet with a physician, do a clinical breast exam every 6 months as opposed to every year. And we do offer some screening for ovarian cancer as well. Sometimes this is the other component to BRCA gene mutations, is a breast and ovarian cancer syndrome. But the screening is unfortunately not great, and it's not a proven intervention. So we have things like ultrasounds, blood tests, but it's not routinely offered just because it's not good enough for this population. We can take it to the next level. We can offer patients often medications that can reduce their risk for cancer. In this specific scenario of a woman who is a higher risk for breast and ovarian cancer, there are common hormone blocking medications, something like tamoxifen, that we can offer to reduce that risk for breast cancer. They take that medication for at least 5 years. It cuts their risk for breast cancer by about 50%. So that's significant risk reduction in a woman that she might find appealing. There are side effects with every medication, and that part she might not find as appealing. So there are things for her to consider. There are pros and cons, but that is an intervention that should be offered to her. And then the other is the birth control pill, oral contraception. Anything that stops ovulation allows us to have a lower risk for ovarian cancer. And when we are using contraception that has a mechanism to stop ovulation as why it works, then we're going to lower the risk for ovarian cancer for that patient as well. So in this case, the birth control pill or something equivalent, taken at least for 5 years during the childbearing period, can cut the risk for ovarian cancer by 50% as well. So that's a common option for those patients. And then we talk about surgery. Surgery is an option that is much more personal. It's a more invasive process for patients, and in some cases it's more of a recommendation, and others it's more of an option. When it comes to things like ovarian cancer, if a woman through genetic testing is found to have a higher risk for ovarian cancer, we're not messing around with that. That's a cancer where, again, we don't have a proven effective screen. It's unfortunately a much deadlier cancer than that. The symptoms are very vague and unreliable. So in these families, we recommend that they have their ovaries removed. It has a very fancy name called a bilateral salpingo-oophorectomy. With our most aggressive intervention, that surgery is recommended at age 35. So that's a big deal, but it can reduce her risk for ovarian cancer by close to 95%. And have an added benefit of reducing the risk for breast cancer because it's taking a lot of that estrogen out of the system. So in that case, we're kind of pushy. We tell a woman this is what we strongly recommend because we don't have great alternative options. When it comes to breast health, it's a little more nuanced. We know that women who have a higher risk for breast cancer, if it falls into a category that's significant enough, we should offer them breast surgery, something like a bilateral mastectomy. But it's major surgery. It often involves reconstruction at the same time. So that's two major surgeries at once. And more invasive, it's more visually apparent to others that you've undergone this process. It's a much more personal process for patients. So it's often an option, not as much, we're not as pushy with that, but it's still an option. And it reduces the risk for breast cancer by about 90%, which is as much as we're gonna get, but it has to be something that the patient is comfortable with. So it's really left up to the patient to decide when it comes to breast management. And even in these most concerning situations, do we want to do screening? Do we want to add a medication on top of that that lowers the risk? Or do we consider something about surgery and let the patient decide what's right for them? And I've used these BRCA genes as an example of this conversation because they're the celebrities in our world. They're the genes that account for about half of hereditary breast cancer. But they're not the whole story. There are lots of genes associated with breast and gynecological health. I just list them here just to give you an idea. It is not that straightforward. We have a menu of genes and genetic tests that we're choosing from these days. They're all different. They all have different cancer risks associated with them. And we need to treat people accordingly based on that. So it's our job as genetic counselors to look at a positive test result and say, okay, what exactly are we dealing with here? Which gene is it? What types of cancers are we talking about? How big of a risk are we talking about? So the patient can get the most appropriate intervention based on that. So it's more of a personalized conversation. It's definitely not a one-size-fits-all approach these days. So for hereditary breast cancer, that's a common conversation we have. Is that perhaps the most common referral indications that we see in our office are for patients who have concerns about breast and ovarian cancer risk. There are impacts for men in these families, again, male breast cancer, prostate cancer. There can be some gastrointestinal cancer risks as well. But perhaps the underlooked risk that we see and that we probably should be seeing more of are patients who are at risk for these hereditary gastrointestinal cancer syndromes. They have a soft spot in my heart. I find them to be particularly fascinating because the genetics of them are super complicated in ways that I do not plan to get into with you today because it's way more than you're bargaining for. But these are individuals who have a much higher risk to develop colon cancer and other related cancers. They tend to also develop more polyps than the general population, and those polyps can become cancer faster than in the general population. So we need to address that with offering screening more appropriately. And they can have a higher risk for other gastrointestinal cancers like upper GI cancers or pancreatic cancers. They also can have a higher risk in some of these families for things like gynecological or breast cancer. So again, it's that same concept of which gene are we talking about, what type of cancer risk, and how do we modify that? But it's more focused on gastrointestinal in that case. The most common hereditary colon cancer syndrome is Lynch syndrome. Lynch syndrome probably isn't that much less common than having a BRCA mutation, but it doesn't get nearly as much attention. About 3 to 5% of all colon cancers are caused by Lynch syndrome. It's really a colon and uterine cancer syndrome because it's also associated with a significantly higher risk for uterine cancer. And honestly, this is pretty much a public health initiative because we have really effective screening and management in these families. So it really behooves us to identify individuals who have a hereditary colon cancer syndrome. And it's about the same proportion. If we took all of these hereditary colon cancer syndromes and combined them, about 5 to 10% of all colon cancers are hereditary, which is about the same as with breast cancer. So it's perhaps just as common, affects men and women, but it's something we don't talk about as much for probably lots of different reasons, but it's pretty important in my opinion. Just to give you an idea of what risks we're talking about, this is Lynch syndrome. Individuals who have a mutation, one of these genes, can have upwards of an 80% lifetime risk for colon cancer. That is much more than the general population. Obviously, that's a very big deal. The general population risk is about 5%. It's, again, a uterine or endometrial cancer condition as well. There can be as high as a 60% chance for uterine cancer in women in these families. So we want to be aware of that and offer them the appropriate intervention. And then it's higher risk for upper GI cancers, ovarian cancers, other things that are part of that spectrum as well. What do we do about it? If people have been diagnosed with this condition, we start colon screening much younger than the general population. Again, we typically are looking at, the average risk patient starting colon screening at 45 now, which is different than it used to be. If you have Lynch syndrome, we start that screening as early as 20 to 25 years old, so 20 years younger. And they do a colonoscopy every couple of years. They get into their 40s. They continue to have a colonoscopy every year after that. And we do that because we know it works. By doing this screening that aggressively, we are able to reduce the incidence of colon cancer in those individuals by as much as 80%, which is huge. It almost normalizes that risk for them. And then we talk about upper GI screening to screen for small bowel and stomach cancers. And we talk about gynecological screening, which isn't great, and urine screening for some of the less common conditions like bladder cancer in these families. We also talk about surgery. There are some patients who might have a portion or their entire colon removed if they have a change in these genes. And then the big thing is the gynecological surgeries, things like hysterectomy and oophorectomy, the removal of those ovaries again. So it is customizing risk and customizing intervention based on that. But I would say, and this is the data that I try to impart to my patients who have a higher risk for colon cancer, if we do screening as appropriate, that person's, again, likelihood to develop that colon cancer is reduced to almost the same as the general population. And their life expectancy is normalized. It becomes the same as the general population, because even if they were to develop something like a colon cancer, it is much more likely to be an early stage colon cancer that we can treat effectively with maybe a minimal surgery, as opposed to something much more devastating like a stage 4 diagnosis where we're doing chemotherapy and things just to try to preserve that individual's life. So it is less focused on. It's something people maybe don't talk about their colons as much, but in our world, just as important, if not more important, because we really know these interventions work. And it's almost a shame if anyone develops like a GI cancer at this point when we have the opportunity to intervene and to prevent that. So hereditary cancers are a big part of what we do. They are a passion of ours. It's really preventative medicine. I want to switch gears a little bit and talk about the heart too, because this is an up and coming area for us. It's probably about 10 years behind where we are with hereditary cancer syndromes, but we are starting to see a lot more patients for heart health in our office. And there are some common indications that get them to us. The most common are patients who are diagnosed with a type of cardiomyopathy, which is an issue with their heart muscle, often with their muscle being too thick, which starts to cause weakness and overcompensation. It just exacerbates the issue. These are the more common types of cardiomyopathy, all of them with a possible hereditary component. Honestly, these are virtually always hereditary conditions. It's just a matter of, do we have a test good enough to find it? So we work now very closely within Wellstar with our cardiologists. When they have a patient diagnosed with one of these conditions, that becomes an automatic indication to referral to our office to try to explore the underlying cause of their diagnosis. Is there something hereditary going on for them? What does that mean for them? What does that mean for their relatives, which we're going to chat about a little bit more. But this is, something that we were the first in the state of Georgia to offer adult hereditary cardiac genetic testing. We started doing that about 8 years ago, and this has become about 20 to 30% of our patient population at this point, because we're learning more and more about how common some of these conditions are. Just to give you an idea of what we're talking about, Patients are often diagnosed with cardiomyopathy if they start to experience this cluster of symptoms. And then looking back in their life, they often tell me, oh, like even as a child, I was short of breath more than my friends. I was, not in bad shape, but I couldn't keep up in PE class when I was younger. They have palpitations, they have syncope or fainting. They can have issues with heart rhythms. They might see a cluster of stroke in the family. These things would all make us suspicious. These are incidents that can unfortunately lead to things like heart failure, and it could be that cardiomyopathy was the cause. So our goal is to find people before these symptoms develop, but if they got to this point, if they're with the cardiologist, if they're given this diagnosis, that's where we might come in on the back end and try to understand what led to that diagnosis for this individual. The genetics of the heart are a mess. These are just some of the genes associated with just cardiomyopathy. There are a lot more genes involved. It is a very complicated genetic testing process because there are overlapping features with different conditions. So I would encourage you, if this is a concern of your family, work with a cardiac specialist in genetics, because it's something that is more nuanced, perhaps even than cancer genetics. So we really want to make sure that the patient's in the right hands of somebody who knows how to interpret these genetic testing results. We've gotten to the point where our cardiac genetic testing involves hundreds of genes, and every one of them is a little different and has a different risk and a different symptoms we might be worried about. So it is a very complex discussion for these patients. Why would we want to know? What's the point? In these families, for example, if we know that there's if we know that there's a cardiac condition, the next step is to offer screening to all of their relatives. So if you know you have cardiomyopathy, your cardiologist will say, now all of your children, your siblings should have baseline cardiac screening, and then should perhaps be followed up down the road. It usually involves things like an echo, an ultrasound of the heart. If we know that there's a genetic test and that there's a positive genetic test, that allows us to prove that we've identified the actual cause of your cardiac diagnosis. But now it also lets us figure out who else in the family is at risk, because we have the opportunity to test them too for the same thing. Which of your children, which of your siblings, and perhaps in some scenarios, your parents, other relatives have inherited this gene as well. So we can focus our efforts. Instead of just doing some, casual cardiac screening for everybody, we can say, this subset of people in this family, these are the folks we need to watch more closely. These are the folks we need to screen every year or so. We need to do the echo, we need to do an EKG, monitor the rhythm of their heart, so that they can be considered for things like having a pacemaker put in earlier, or having medication proactively, so they don't get to the point of having those symptoms that we talked about earlier. And then on the contrary, if then your child, for example, tests negative, we don't have to do as much of that screening intervention, because we know that they did not inherit the gene that caused your diagnosis. So we don't have to be as aggressive at how we follow them. So it helps us to differentiate who's at risk and who's not. It gets a little complicated if we do genetic testing on you, the individual who has a heart condition, and it's negative, because it could just be that we don't have a good enough test, because the genetics of the heart are a mess and we don't know everything yet. So we might still talk about some screening for relatives just to be on the safe side, again, because they still share genes and environment in common with you and we don't want to miss anything. So the genetic testing helps us to figure out what that screening might look like for relatives as well. I want to spend a little bit of time specifically talking about a condition that is incredibly common, that is genetic, called familial hypercholesterolemia, which is a very fancy way of saying very high cholesterol that runs in families. This is probably one of the most common things that we find of all the genetic testing we do. About 30% of our patients we test who are coming for this condition, we find a mutation in, compared to about 10% of other conditions. So we're doing better. We have a better test for these families. And this is something that's probably much more common in the population. These are your folks, and I'm sure some of you are these folks who have high cholesterol, and it just doesn't fit. It's not something that seems to be impacted by diet, exercise. Again, you could be eating right, exercising, and you just can't get that cholesterol below the numbers that we're looking at. In this case, again, we're looking at these high cholesterols in the range that you see on your screen. These are folks who probably have some hereditary predisposition to their high cholesterol. And that's a big deal, because we need to treat them differently than other folks with high cholesterol. They need to be monitored more closely. They need to be offered medications more aggressively, because if they are not, they have a significantly higher risk to develop premature heart disease, stroke, heart attacks, all of these things that we want to avoid. So this is another like public health initiative to find these folks who have familial hypercholesterolemia, and genetic testing is one way that we can do that. There, again, it's a better test. We've identified the majority of the genes that are associated with familial hypercholesterolemia, not all, there's still this portion we haven't found yet, but it's a smaller targeted test of only 4 or 5 genes that seem to be the culprits. And we're even getting to the point now where there are some like gene medication interactions. So if you have a mutation in one of these genes, it might mean a different high cholesterol medication for you, because we understand this works better in you because of the underlying cellular cause of your high cholesterol versus somebody else who might not have a genetic explanation, and the medication might not be the right fit for them. So it's even starting to influence like prescription choices by your cardiologist, which is why they're sending us a lot of their patients to make sure we're offering them the right treatment. So I just want to highlight that as a big deal that we're seeing in the in the hereditary cardiac world. And the other, just before we close, I want to just introduce you to amyloidosis. This is another common condition. We're hearing more about it. A couple commercials on TV for this recently, because there are some therapeutic medications for this. This is people who have a condition that causes their body not to break down something called amyloid, which is like a plaque that we can get, and it can deposit itself in organs that of our body, one of the most important being our heart. It can also affect things like our kidneys. Sometimes it can affect our joints. So this is a condition that is sometimes genetic. There's a subset of this that we call the TTR amyloidosis. These are folks who have a mutation specifically in this gene TTR that cause their amyloidosis. There are other like medications that can cause it, other heart conditions that can cause people to develop amyloidosis. But if there's something hereditary going on, that's a bigger deal. They have a much higher risk. There are very specific medications that these patients benefit from, and they have symptoms much earlier and more aggressively than people who don't have a hereditary cause. So this is another area of like public health focus for us, is to identify these folks who have hereditary amyloidosis, and we're seeing a lot of these patients in our office now too. These are the things that make us suspicious. If you have a known relative who has a mutation, if you see slowly progressive neuropathy or like numbness in the nerves, especially in addition to cardiomyopathy in a patient, those are a combination that makes you think about something like amyloidosis. You can see some heart studies that are unusual in these patients. Again, kidney problems that can pop up in these patients. Another common thing is carpal tunnel syndrome in these families, in addition to heart concerns. So we're seeing our cardiologists ask more of these questions to try to identify these patients. We're seeing even some people like an orthopedist might pick this up, or a hand surgeon. So starting to influence other areas of medicine as well. So a much more common indication than we have seen in the past. And that's kind of my tour of the common hereditary interventions where genetic testing can be helpful, mostly in the cancer space and in the cardiac space. I just wanted to end with some common questions that patients ask us, just so that you're aware of them. First, to keep in mind that not all genetic tests are created equal. You can order genetic testing on the internet for some things. I would just say, be a knowledgeable consumer. There are different qualities of genetic tests, or different standards you have to meet if you're doing genetic testing for a medical decision. FDA approved, has to be vetted through a high quality laboratory. If you order some things on the internet, it might be something that is more for like entertainment purposes or ancestry. That's not really giving you the same level of medical knowledge. So just to be aware of that, and to understand that there is typically not a perfect genetic test either. We don't know everything. We don't know everything about genetics. And then just other common things that come up. People talk about like, why would I want to know this information? We usually have more of an empowering conversation with patients. This is information that you could use to make informed medical decisions. So approaching it that way as an additional piece of data that you could have in your toolbox when you're trying to make some of these decisions. People ask like, can I fix my genes? Well, it comes up a lot. We're not there yet, and like maybe 5-10 years in the future, and there's some exciting technology coming down the road. And you might have heard about things called CRISPR, where they're looking at being able to alter people's DNA. There are a lot of ethics involved with that. Things can get a little complicated, but we're not there yet. we can't fix our genes, but we can, going back to the very beginning, perhaps talk about the environment our genes interact with and how we can maximize the potential of our genes. That might be a different way of looking at it. Another common question that people have are, like, is my genetic test covered by my insurance? How much is it? I will say in general, if genetic testing is something that's medically appropriate, if the person meets criteria for genetic testing, it's usually covered by their insurance. We work with that process all the time. We're doing pre-authorizations and the documentation that patients need for it to be covered by their insurance. It's also much cheaper in general than it used to be. Genetic testing in the self-pay arena for some of these conditions is a few $100s. It's not a few $1,000s, so it's much more attainable for patients. People are worried about privacy. There are lots of concerns like, will this go into my medical chart in some way? Could this have a negative impact on me there? What I would say is you have lots of laws that protect you in that process. There are federal, and then in the state of Georgia, there are more specific laws that protect your privacy. Our department within our health system is one of the only closed departments because of that. It's something that is not readily available to other doctors. We have to kind of open the door for other folks to be able to see specific genetic testing results for their patients because of that. So we are very thoughtful about genetic information and making sure that it's something that is protected to the best of our abilities. But again, you do have legal protection about that as well. And again, it's something that is more cost effective than it used to be. So there's usually not a financial barrier for patients. If there's a medical reason or desire to be able to do genetic testing, is usually something that we can get done. So I'm passionate about it. I think it's an exciting time in medicine. That genetics is just becoming more and more a topic of conversation across the spectrum of medical intervention. There are specialists that we're working with now that never even thought about genetics 10 years ago, and now they're routinely sending us patients because it's valuable information for them to have as part of their patient's care. So who knows where we're going to be at in the future, but I can't wait to see what happens. Thank you for your time today. I hope you found this to be very helpful.